So good morning everybody and welcome back to the conference. I think we have actually a very important topic today because as you have all realized there is still scarce data on what we do clinically, and it is of course important to gain more knowledge in the future, to know what is right, what is wrong maybe, and what may be futile. Therefore, we have designed this session here to talk about how to design, perform, and read and interpret clinical ECMO trials. We will have 4 lectures in the beginning and a roundtable at the end, and I really invite you to collect your questions and put them forward towards the end at the microphones. And it is my great pleasure now to introduce Alain to you. Probably don't need any introduction. Alain is Professor of Intensive Care at the Sorbonne University and head of the ICU at La Pitié, which I believe, Alain, is the largest ECMO center in the world. And you have done a number of important trials, so I'm looking forward to hearing your opinion. Thank you very much.
Thank you very much, Thomas, for this kind introduction, ladies and gentlemen. Yes, actually, we need trials in the ECMO fields, and we need maybe newer design, but most of it, we need patient selection for an intervention which is planned or to be tested. This is first my disclosure slide. And to start with, I would like to discuss a little bit with you RCTs versus retrospective series and data analysis, specifically to evaluate the treatment effect. Just for an example, during the COVID pandemic, we were not able to launch a randomized study comparing ECMO versus no ECMO. And it's a pity because during those weeks and months, we have treated more veno-venous ECMO patients in our ICUs than ever before. So we had a lot of retrospective data, database in which there were large collections of patients and data. Some got ECMO, some did not got ECMO, and it's possible to do retrospective evaluation using different types of models. I've listed some here, multivariable model, propensity, score-weighted, case control with propensity or gene matching. And I would like to tell you just a minute about the latest, which is the target trial emulation framework, which has been used in quite a few studies here to evaluate the impact of ECMO. So what is the target trial emulation? Comparing patients who initiated ECMO in the first 7 days, for example, of ICU admission, to those who did not. First, you need to have a huge database in which some patients did get ECMO and some others did not. And then you will design the emulation framework, defining the protocol of an hypothetical randomized study, then emulating this using the available observational data. The first step of any emulated trial is then to define the target trial that would have been conducted if an RCT had been feasible. And you use a retrospective database to define eligibility criteria day by day, and then comparing the 2 strategies. Patients who got, for example, ECMO, those who did not ECMO. Then you define, like in an RCT, a primary endpoint. Might be mortality, day 30, day 60, etc. So it's very similar. Of course, you're working with retrospective data. This is what we did here in a French huge COVID database in which there were more than 4,000 patients here who did receive mechanical ventilation during the COVID pandemic. And we did emulate a trial day by day. On day 1, the patients were categorized in the ECMO group if they received ECMO, non-ECMO group if they did not receive ECMO. And we repeated that strategy day by day up to day 7. This approach is made to eliminate what is being called the immortal bias, and patients were followed up from the date of ECMO initiation or non-initiation until they reach the primary endpoint. So this is basically here how it works day by day, and each day there is a specific sub-study which is created by patients who enter the ECMO trial or those who stay outside who did not receive ECMO. And at the end, you have 7 small trials which at some point will be combined to form the target trial emulation, which will allow you to estimate the final effect of ECMO on survival. So a given patient could be included in the control group in several trials. If it never gets ECMO, it will be in the 7 trials. If a patient gets ECMO, it gets to the ECMO sub-study, sub-trial, once the day he receives ECMO. And this is what we have observed here about the impact of veno-venous ECMO. On the left panel, it's the row analysis showing there is no difference between no ECMO and ECMO in the 200 patients who were treated in France. And the difference appeared when we separated patients treated in experienced centers in blue versus non-experienced centers in red. It is the most sophisticated way of dealing with retrospective data now. It will never be an RCT because obviously in the database there may be some missing values or parameters which might compromise, which might have impacted the outcome of the patient, or patient selection might be biased by the doctor who did select the patient for ECMO for patient A and did not for patient B. But we still need those retrospective analysis, and this framework is a very good one. And then we have RCTs. Sure, RCTs are best because it's the best way here to get rid of the selection bias because you randomize the patient initially. But still, we need to have a close look at the methodology and beyond the methodology, the patient selection and the patient's management. And my first major concern when dealing with RCTs in devices, especially with ECMO, is the number of patients who cross over from the control group to the interventional group, which may just sterilize the results of the trial. And just to mention as an example, the very recent early unload trial of transseptal lateral cannulation here to reduce left ventricular pressure, to unload the left ventricle here. It's a quite complicated technique here to position this cannula in the left atrium. There may be more easier method to unload the ventricle. But the trial was well conducted with the primary endpoint of mortality at day 30. But look here, in the control group, 50% of the patients get a cannula in the right atrium within 12 hours, so very rapid crossover. So, well, you cannot demonstrate a benefit of a strategy when the rate of crossover is so high. And you end up with a conclusion that early routine unloading does not impact mortality. We have also discussed a lot the ECLS shock trial. And this is a point where also we need to stop a little bit, because this right from the methodological point of view is perfect. The protocol was well written, the management of the patient in the protocol was perfectly precise, but we, as you know, got a negative neutral study. And did actually this trial close the debate? Well, I'm not sure. Okay, there was no difference between the two populations of patients. The mortality was strictly the same at day 30. There was no difference between the subgroups. But, once again, should we abandon ECMO for the care of patients who have acute MI cardiogenic shock. We need to always interpret the results of that study, of these studies, in the context of the patients who were randomized and in the management of the patient. This study ended up with a rate of crossover to a device, whether it is the impella or the ECMO, close to 1/3 of the patients. So once again, there's very little chance to demonstrate the benefit of a technique within the context of an RCT. So the conclusion should be, in the context of this RCT, with the population who had been included and with the management which has been used, and with the rate of crossover to a device of 30%, there was no difference in the outcome of the patients. And when you read the abstracts, actually, it not said that. It said that ECMO does not improve the outcome of the patient if used routinely. I do not agree with that conclusion. And then we have to move forward. You see that ECMO is for years, has been used for years for extremist patients, those who have the most severe cardiogenic shock forms. But then now, is it ethical to randomize a patient who is in class E? Patient is almost dying, a lactate over 8, unconscious, very, very low cardiac output. If the protocol is well written, there's going to be a crossover possibility within minutes post-randomization. So is it really reasonable to use this kind of design? Not to mention, and it's very surprising also here about the patient selection here, some very unusual constatation and characteristics. It's about the rate of patients who had cardiac arrest, which was close to 80%, which was never seen before. It was between 40 and 50 in previous trials, and in the latest danger shock with the impella, it was even lower to around 20%. And those ECLS shock patients, not to mention that the rate was very high, but the duration of cardiac arrest was also very prolonged in most patients. So this ECLS shock trial is a trial of cardiac arrest patients who had prolonged cardiac arrest, who received PCI and then ECMO, and 1/3 of them were recruited with ECMO. We do not know the hemodynamic characteristics of these patients, and specifically, there was no mention of the cardiac index of these patients. And knowing that a lot of patients with cardiac arrest will develop vasoplegia with a preserved or sometimes even increased cardiac index, there's a big question here of the hemodynamic profile, which has been the profile of those patients. And we know that ECMO does not rescue patients who have preserved cardiac output 4-5 liters per minute. The machine will not be better than the native heart in this situation. It's only if there is a profound low cardiac output syndrome that ECMO can rescue the patient. And when looking at the reason for unloading, it was clearly protocolized here. There was less than 3% with a low cardiac output syndrome in ECLS shock, only 3% with a time velocity interval below 10. So it means that most of the patients had the preserved cardiac index here. And once again, when going to the SCAI classification, SCAI C, it's highly recommended to measure the cardiac index, which should be less than 2.2 liters per minute per square meter. And it's even worse, of course, for DNE patients. And so this is something we know. It has been also described for septic shock patients who might be rescued by VA ECMO only if they have a low and persistent cardiac output syndrome. This is something we also had observed in our large series was published in JACC last year. The patient with vasoplegia shock had a mortality of 100%. This is not possible to rescue those patients because most of them, once again, they have a preserved cardiac output. And in relation to this very specific phenotype, it's not unexpected that the duration of ECMO was very short, was only 2.5 days. It's clearly in relation to the fact that well, these patients maybe did not need ECMO because they had a preserved cardiac output. When looking at the literature, duration of ECMO for acute myocardiogenic shock, between 5 and 7 days. So, well, big question mark here about the population of patients here. Management, it was well protocolized in the protocol they wrote, but we ended up with less than 6% of LV unloading. The expected number would have been between 50 and 60, maybe 70%. Why is that? I don't know. And probably we're back to the same problem of the hemodynamic phenotype that the patient initially. They mostly used the Impella, as is the case in Germany. But once again, these numbers are very low, and we know from retrospective analysis that there's been a major benefit associated with unloading the left ventricle in patients on VA ECMO. Here's the EuroELSO database. Mortality reduction was 16% crude, and it may be up to 30% in other series, and the timing also count. If you decide to unload the left ventricle, should be very rapid after ECMO initiation. One of the last slides, the reason for death also, it's very important to have a look at the supplement. Same for the danger shock. There's very surprising elements in the danger shock in the supplement. Here, there's the reason for death. Look at the reason for death also for that danger. Reason for death, half of them are refractory cardiogenic shock. Why is that? Why a patient on VA ECMO will die of refractory cardiogenic shock? Did the patient was weaned from VA and die later on of a refractory cardiogenic shock? Was it too early? We don't know. Also question for the control group. Why did so many patients die of refractory cardiogenic shock when it was possible to set up ECMO? Okay, so it's very, very difficult to run these RCTs. The population is not just MI. The patient for cardiogenic shock is also heart failure patients. The determination of the sweet spot is very difficult. For cardiogenic shock, it might be SCAI C plus D. Once again, plus class E patients, I have a doubt. This is something we had summarized in with Susanna and Bruno in a review paper here of all the challenges here from the selections of the patients. The potential benefit should be weighted against the potential complications of ECMO, and also a very important point about the management of the patients in those trials. I did not mention the other sophisticated ways of doing trials. There might be Bayesian trials, there may be platform trials, adaptive design, but whatever, we are back to patient selection. If the selection of the patient leads to a super different population from what we see every day and for what we all believe that ECMO will help, even with the best design possible, you will never reach the conclusion of a benefit of the strategy. And with that, I would like to thank you again for listening and invite you to Paris to our meeting in late June. Thank you so much for listening.
Thank you very much, Alain. And as Thomas already said at the beginning, we go right over to the next presentation and do the discussions at the very end. So as next, it's a great pleasure to have Jan Belohlávek here from Prague, Czech. He's a professor of medicine and the deputy head of the department and ECMO group coordinator in Prague in Czech. It's up to you.
Thank you very much for inviting me. This is a little preliminary introduction to a project that has been developed and designed in a cooperation of the consortium of almost 40 entities, and among those 14 clinical high-volume cardiac arrest and ECMO centers in Europe. And the aim of this project is to assess eventual role of ECPR in a new multi-center trial. And I'll try to convince you that we need a new trial based on what we have evidence so far. And because I had talked many times, and the others also, on the evidence on ECPR, I'll just jump into this project. So why Osiris? Osiris is an Egyptian god of many things, but mainly afterlife, the dead, and the resurrection. So therefore, this is the name of the project. And there is, the project is kind of a large, and has three major objectives. What we have discussed here in this Congress repeatedly, that we need a randomized controlled trial, multicentric, well-performed, with a robust methodology to provide trustworthy data. So this is our objective number one, and this would be a multicenter randomized controlled trial of ECPR-based approach versus conventional-based approach in refractory out-of-hospital cardiac arrest. Even more importantly, however, and that's the reason why I'm actually introducing this project here, and I was asked by the scientific committee and the steering committee to introduce it, because EuroELSO is a partner of this project, is objective number two. The aim is to collect real-world data on current ECPR use and outcomes in Europe. You have heard a presentation from Germany just a couple of minutes ago, and the other registries showing that the outcome may not be the optimal. Maybe the intervention is not being well performed, or maybe it's not performed for appropriate populations, in appropriate setting, in appropriate regions. So what we want to do in this second, which originally has been named as a registry, but the registry has a lot of, I would say, legal definition. So today we use the term open data platform, and we will develop open data platform to share our experiences on ECPR. And I'm inviting and encouraging all centers around Europe who are providing ECPR to join our effort, to join ECPR working group of EuroELSO. That would be a leading body for this objective number two. And the third, of course, if we develop the data, if we succeed to prove the benefit, hopefully, then we have to disseminate and improve the care around Europe to avoid not well-performed intervention, which may cause a lot of resource wasting, a lot of suffering for patients, for their relatives, and for the nursing and physician staff. So kind of improve ECPR dissemination in different regions across the Europe. This is in other words, schematically what we will do. So there is a high need on the left-hand side, and the reason why we are doing it, there's a high need to improve outcome of out-of-hospital cardiac arrest. On average, has been reported of 8% survival for out-of-hospital cardiac arrest, but I've shown a couple of minutes ago the paramedic trial, the randomized trial from UK, where the survival was about 2% for good neurologic outcomes. So it's very poor. So anything we can do for such a large population of patients, which is over 300,000 people just in Europe who die every year from cardiac arrest. So any improvement might have a profound socioeconomic and general benefit. So the part number one is up there, the multi-center RCT, 14 expert centers, which have been chosen based on very strict criteria of at least 100 cardiac arrest cases per year and 50 ECPR cases per year. Then we develop the robust methodology. We will also perform HTA analysis, and hopefully we will positively test the hypothesis that patients might benefit from ECPR, and that also this intervention might be cost effective. The second part is this OSIRIS open data platform, which means we would like across the Europe, similarly how the ELSO is doing the ELSO registry, but within the Europe and just ECPR, to develop a network of hospitals and ECPR providers to gather those fragmented databases into one, and to perform advanced data analysis, and maybe to look how it's performed first, and second, how to improve, and whether there is other data or other markers that might show benefit from certain populations patients because the multi-center trial will focus on shock algorithms, but in the open data platform we will analyze all patients and all ECPR, which is being provided even for non-shock algorithms. So the aim of this is to establish, based on the result, the best practices and improve patient care, and at the end, in the lower part, to standardize the ECPR process, because if it's not standardized, if it's not protocolized, maybe that's the reason why the results may not be so optimal. We would also involve the public, patient and public organizations. We do have our patient organization for cardiac arrest survivors, for ECMO survivors, and it's been evolving around the world that the patient also is needed to have a feedback from what we are doing, and their opinion is of utmost importance in this. So within the project, several of partners are responsible for large-scale training and educational programs to harmonize the way how this very logistically demanding invasive procedure is being provided to focus and to aim to the best results. And this all in collaboration with scientific societies, and there the role of EuroELSO and ERC, European Resuscitation Council, which are established partners and also supporters, which is European Society of Cardiology, ACVC, and also European Society of Intensive Care Medicine for this project, for possible eventual European-wide uptake and system improvements, which may end up with saved lives and costs. So this is how the project is designed. Why new trial? The rationale for that is obvious. The published ECPR studies, and I'm talking about the randomized trials, which are 3 basically, vary widely, and there are differences around Europe also between emergency medical systems about the eligibility criteria, about the ECPR strategies, whether in or out of the hospital cannulations, whether at the cath lab, emergency, ICU, whatever. And the randomized trials we've been talking many times about have a lot of limitations. So the first arrest, only 15 patients randomized to ECPR strategy, and in the conventional arm, the intra-arrest transport, which we know that is less effective than the transport on site, was followed by, again, conventional CPR, so those patients were disadvantaged in the care as has been provided. Our Prague trial was definitely underpowered for the primary outcome, and we also allowed crossover, despite the fact the crossover was low and was defined still, the crossover influenced the final results of the study. And most importantly, those 2 plus-minus positive studies, or at least with a sign of positive results, were single-center trials of high-volume centers experienced with both ECMO and ECPR. So, and then you know that the multi-center trial from Holland showed that if you just take it and spread it among 10 centers, who do have a cardiovascular department and do have some experience with ECMO, but a very low volume for ECPR, it doesn't work at all. So this is a very important clinical question, which remains whether ECPR strategy may be recommended for widespread use in different cities and countries, and this is still unanswered, and this project should answer this question, hopefully, definitely. Therefore, we truly think that a multi-center study is warranted on this. What are the hypotheses? They're very simple, very straightforward. The question is whether ECPR-based approach, which is important, so ECPR service provided either in or out of hospital, I mean the cannulation and start of ECPR implementation, when compared to on-site ACLS, improves survival in selected adults, defined later, and can be successfully implemented in different cities and countries, and that's the question. What is the proposal? So as I said, multi-center international open label randomized trial, however, with a 2-to-1 concealed allocation, because there is a lot of science and evidence for a possible benefit. Therefore, the 2-to-1 allocation of the refractory patients to ECPR versus CCPR-based strategy. So ECPR-based strategy means, as I said, hopefully ultrasound-guided in-hospital or out-of-hospital cannulation. CCPR-based strategy means on-site ACLS until sustained ROSC achieved or the patient is pronounced dead, with an eventual option to transport the patient for continuation of the care in hospital. We will strictly prohibit crossover. Therefore, some of the centers which might be interested in participation could not participate, because if the ECPR was pronounced or was perceived as a standard of care in those centers, they were not willing to randomize patients, and they perceived it ethically not correct. We don't feel that. We feel complete opposite. We feel very strong. We are strongly convinced that we need to randomize those patients and keep them and prohibit crossover, because if you don't, you will never ask the question we need to answer. We will use pre-hospital web-based randomization system electronically. Of course, ECPR cannulation will be encouraged either in hospital or out hospital based on ultrasound, or in hospital based on X-ray, whatever the practice is in the respective center, and out of hospital, of course, ultrasound guided or open, whatever the practice is. We will standardize, or actually it is already standardized, for the post-CPR care in both arms. Invasive coronary angio is encouraged in both arms, whole body CT also encouraged, and a TTM of 33 or avoiding fever plus neuroprognostication according to the guidelines is also encouraged. And we will stratify after the randomization for several different interventions, asking many questions. So at this point we already have about 35 planned sub-studies to look at TTM 33 versus 37 in CPR never answered questions, a lower flow or higher flow, target flow in patients, and many others. Our primary outcome will be 90-day survival, just it. It's a most bias-free study endpoint, and the secondary outcomes would be a neurological outcome based on modified ranking and quality of life. So for the open data platform, we would love to invite you to become members of ECPR working group, which will be highly involved in this. It's very easy, just contact myself or contact the EuroELSO ECPR working group, which I'm chairing actually, and we would be happy to have you as a center providing data for this open data platform. This will be managed by our institution, University of Munich, where there is an advanced way how to analyze the data, and this is the same team as is used for the EuroELSO and ELSO harmonization of data common models to be provided to ELSO registry to even more improve the way how to provide the data, to ease this process, to make it automatic. So at the end, our effort, even in this project, is to make possible the automatic provision of the data after some minor manual correction. So at this moment, usually data are provided manually. It takes a lot of time for people entering the data into registry. Our aim is to come with a service that would harmonize your hospital information system with a system of the open data platform for the majority of the data to being provided automatically, and of course based on the European Union regulations, GDPR compliant, and all those things that are around. The data set for the registry is very limited, very easy. Some patient characteristics, cardiac arrest characteristics, post-ECMO treatment, and outcomes, and then that's it. So if you do it manually, my estimation is 20-30 minutes for a case, and that's it. But I think the information we can retrieve from this project would be huge and potentially might change practice in the future. This is our contacts, and thank you very much for listening.
Thank you so much, Jan, for this great talk. I have the great pleasure now to invite Aparna Hoskote on the podium. Aparna will talk to us about pediatric trials.
Thank you, Alain, and it gives me great pleasure to stand here and talk a bit about the future trials on ECMO in the pediatric population. My disclaimer is that I'm not a great researcher myself, but I've taken a lot of notes from my colleagues and friends who do a lot of research in children. I start off by saying this: children are unique. They're not little adults, and I think that is based mainly on the fact that, you know, we look after children of different ages, different weights, physiology is different, the disease etiologies are different, and I think trying to contain all that in a large study would always be very difficult. In the 1960s, the lab research showed that extracorporeal circulation can be maintained using membrane oxygenator. In the 1970s, the first clinical trials of ECMO could sustain life for days and weeks, leading to organ recovery. And then finally, in the 1980s to 2000, ECMO became a standard practice for neonatal and pediatric respiratory and cardiac care. I'd like to remind everybody that the critical clinical trial led to the continuation of ECMO and the use of ECMO was a prospective randomized trial of ECMO in newborn respiratory failure, which was published in 1985. So we are here now in the 20s, and we are trying to look at what the future holds for children. I'd also like to remind people that ECMO is not just the technology, there is a patient, and there's the patient journey which we need to improve right from the time the child gets referred and to the time the child is decannulated, discharged, and at home in the community. So let's have a quick look at the research journey so far for ECMO in children. And you can, as I said earlier, in 1985 was the first publication. And you can see this was by Professor Bartlett. We call him the father of ECMO. And it started off with 10 patients. And that went on to Pearl O'Rourke study in 1989, 29 patients, and in 1993, 41 patients were enrolled by Schumacher et al. And all these studies showed that there was an advantage, a survival advantage. The next big study came in 1996, which was the UK collaborative ECMO trial, looking at the neonatal ECMO, published in Lancet, and that recruited 185 patients. And it showed that there was definitely a survival benefit, and there was no disadvantage of these children in terms of neurodisability going forwards from recovery from ECMO, and the follow-up was for 1 year of age, 4 years of age, and 7 years of age. And then later on, as ECMO and the NEST study for the use of hypothermia in identifying an improvement in neurological outcomes was a NEST study published in 2013, and it enrolled 118 patients. And I'll talk a bit more about it a little later. So I think one of the things that these studies looked at was the use of ECMO versus standard care. And we all know that standard care is extremely variable between different institutions, and it also reflects a lot of the pre-admission care and the pre-ECMO care. There were some lessons learned from these studies: the adaptive design, the controversy to randomization process, the consent processes used then, and the ethics of doing such trials. And this list here, lists all the publications. And I was curious to note that there was even a publication here where it says a Harvard study on newborn draws fire, and the doctor was faulted for limiting life-saving therapy. And you can see that these studies led to a lot of questions about the ethics of doing studies when there was a clear survival benefit. And this raised the question of RCTs. The newborn acute hypoxemic respiratory failure and the need for ECMO changed with the use of inhaled nitric oxide. And we then started getting more information on the use of inhaled nitric oxide, and the RCTs based on using inhaled nitric oxide definitely showed that that improved and that actually reduced the need for ECMO. And I think over the years, the utilization of ECMO for newborns has reduced. Now, having said that, when you look at this study, the UK ECMO collaborative trial, and 20 years later, we all know that trial life is, or research paper life is not very long, but this study has held for the 20 years now, and you can see that this diagram documents how the first use of neonatal ECMO was in 1975, and then this study went on to show that there was good follow-up, and then that led to the CESAR trial in adults. Now, we published, Melanie Bambia, myself, and Marie Gregorian published this paper on just as a review on pediatric ECMO research. Now, whilst we know that ECMO as an intervention has been used in neonates and studied in neonates, there are no trials for ECMO intervention in the pediatric or the non-neonatal children with critical illness. And there are no RCTs, and in fact, several landmark PICU RCTs have excluded ECMO patients, like the TRIPECU study, or have considered ECMO as a study endpoint, like the use of calfactant in pediatric acute lung injury. So today, there remains a controversy of whether we use, and the ethics of whether we use randomization to ECMO or conventional management in children. And so pediatric or non-neonatal ECMO studies are primarily registry-based case series, case control studies, and using historic control cohorts. If you look at the current clinical research on pediatric ECMO, you'll find that only recently we've started having lots of publications coming up, and you can see that from the PubMed figure. But if I was to put trials in this group, that number would be significantly lower. Now, we know that there are several knowledge gaps. We know that there are methodology challenges, infrastructure and funding issues, but we need research. We need research to inform outcomes, inform ethical questions, and inform ECMO education. But we know that the variability in ECMO practice is significant at individual, institution, and country level, and there are low numbers that pose significant challenges to trial designs. And what are these challenges? Small numbers, heterogeneity of ages, complexity in clinical diagnosis, ECMO equipment, the rapid advances in technology, and the feasibility of enrolling critically ill children in clinical research, the varying thresholds for ECMO initiation, and the variability in ECMO management. But we need rigorous data, we need high quality evidence. And what can we do to improve this? We know that under many centers are low volume centers. We know that the diseases is significantly different, especially when you compare it with adults. And you can see from the COVID-19 study, the small numbers of pediatric ECMO made it harder to convince any decision makers that the topic is important and to access resources, and harder to get the messages heard. Similarly, when we looked at the EuroELSO registry, looking at median center volume per year, you can see between Europe and US, there's a significant difference. And by and large, European pediatric ECMO centers have an annual center volume of less than 10 per year. We also know that centers differ in management, and from the BATE study, we know that each center, as you can see, each hospital had a different bleeding event and a thrombotic event proportion that was significantly important. And similarly, we can see that enrolling children in critically ill environment can be very stressful for families who need to understand and accept the patient for consent. Now, a little bit about the NEST study here, because it's only one of the few interventional studies during ECMO that have been published. 111 babies and RCT, systemic hypothermia for 72 hours, took 6 years to complete. And the main method here and the outcome was to look at a mean cognitive score, which was between the two arms, to to detect a 10-point difference, and here the difference was actually only 2.6%, though they recruited 111 babies, and at the end of the day, whilst they had very good recruitment and completeness of follow-up, what was important was that this was in the end a negative trial. And so there are important sample size and deliverability issues. We know that there are major knowledge gaps, optimal timing, interventions, weaning strategies, and importantly, outcomes. But when we come to looking at outcomes in children, what is good outcome? Is in-hospital survival rate a good outcome? Is late mortality? Or is it actually the neurodevelopmental and functional outcomes? And we know that the types of studies vary in their primary outcomes. We know that a lot of the data is uncaptured, like this iceberg here, that we see only the tip of the iceberg and we don't measure a lot of the neurodevelopmental and the functional outcomes. And again, coming to the point that we need good epidemiological data, and we need to have good standardization of ECLS care. Looking at COVID-19 and ECMO, when we were trying to look at a prospective survey in 52 European centers, it was very difficult to get the number of children who had received ECMO, and fortunately we did have, but we are not sure this was entirely wholly representative. So small numbers make research prioritization tricky, and the allocation of resources becomes especially very challenging. Now, when we know that we have to use meta-analysis as a primary step in scoping for research, but if you look at meta-analysis and you ask the questions, now this is an example I've picked up here, does eCPR compared to conventional CPR improve outcome? You can see that it draws on 28 studies here, 26 are retrospective case series. Many of them are not from Europe, the very, very few studies, and they're usually supplemented with propensity matching, which comes from, again, large registries like the Get with the Guidelines registry here, which is based in the US. So it does show an improvement, but in survival, but we need to know about the neurological outcomes. Now, ECMO research needs a diverse study team. We know a range of expertise is required, not only clinicians, but statisticians. We need coordinating centers. We need data monitoring and safety boards. And it's complex to organize patient and public involvement. And parents might also find it quite challenging. And when we asked our set of parents, what might it be difficult for them to participate? And there were questions like, it's confusing, that things are going on, we don't know what's right. We would have to have a chance to regret if subsequently you found that the research treatment did end up as a higher risk. Or I'd want to know if 6 months later there were some long-term side effects. And I think, but everybody, the parents did agree that research is really important, otherwise ECMO wouldn't ever have happened. So hearing from children is also very difficult. And again, when you look at outcomes, is it the health quality related life, the patient-focused outcomes are very difficult to identify and register. Now, is there equipoise? There is equipoise, and even if you look at pediatric ARDS, there are multiple knowledge gaps as to when you put the patients on ECMO, what their expanding indications for ECMO, and diminishing contraindications. And there are multiple knowledge gaps, timing, interventions, mechanical ventilation strategies, strategies for weaning, long-term outcomes. But here we are now in 2023, and I'm coming to the end of my talk. So there's basic research, we need that, epidemiology, registry-based studies, we need consensus definition, and we finally need that to lead the foundation for clinical research. So we know that there's been a very good initiative called the ECMO Central, the Academic Research Consortium, looking at developing harmonized ECMO adverse event definitions for clinical trials and regulatory evaluation. And this leads to establishing a common language and core definitions. The current observational studies is the ASCEND study led by Ryan Barbero, and I'm sure you'll hear more about it in the pediatric research session this afternoon. And that looks at ARDS in children and ECMO initiation strategies impact on neurodevelopment. And again, multi-center study across, Europe and US. The next study that I know of is the BEAM, the biomarkers in pediatric ECMO, which has finished recruitment. It's a multi-center prospective observational study. And the primary goal here is to develop and refine a brain injury multi-marker panel. And again, centers based mainly in in US. The Aachen study has completed 318 patients. So again, it's a 12-month follow-up rate here, which is very good, of 88%, and we hope to get more data in the coming years. The other multi-center trial, which has, I'm going to mention here, is the Titus study, and this is a multi-center RCT, and it's looking at, again, an intervention on ECMO, looking at transfusion of red blood cells in ECMO, and led by Peter Alexander and Ravi Tyagarajan, and you can see that their aim is to get 228 patients, and so far they've enrolled 81 patients, and again, a multi-center trial based in US and Canada. Another multi-center trial here is looking at the platelet thresholds, and at a lower platelet threshold as compared to a higher platelet threshold. Again, the study has, from Yale University, has enrolled 23 patients out of 50 in their pilot trial, and they have good consent rate, and you'll hear more about this later, the ecstatic study. There are further 2 more studies I'm going to mention here, which are funded study. One is the Pelican study, looking at machine learning, again, multi-center with 10 sites, looking at retrospective data and trying to understand with using neuroimaging scores to deliver personalized algorithms to predict timing of neuroinjury. And the Cardio Help study, which is again a multi-center study, looking at the safety and effectiveness of Cardio Help for VA ECMO up to 30 days. So we know that we need to move on to newer trials and methodology, and we've already heard a little bit about this, the adaptive platform trial, the Bayesian APTs. We know that the registry has an important role as well. The ECMO, the ELSO registry, is the world's largest ECMO patient registry and the largest community of ECMO centers, and we should use the registry for research analysis of pooled data, and the trends and signals can be used to develop prospective studies. Now, we can also embed the studies in the as an RRCT, and there are some key pillars when you embed such studies: quality of data collection and having very good study process and endpoint validation. And different designs can be used, different randomization methods can be used, and again that there are multiple advantages, but there are also disadvantages which we need to bear in mind. And the key benefit is that you can embed a change into the registry, so you can definitely develop that much earlier than any other RCTs. So, but roles and responsibilities are important, randomization is important, and many factors like data monitoring is very important. Last 3-4 slides on the next generation of evidence-based, and that's the adaptive platform trials, which are multi-stage, multi-arm study designs, and you can see here different things, and I won't even pretend I understand all this very well, but all I want to show here is that we need to look forwards into artificial intelligence and precision medicine. And I'm going to say here that not all platform trials are adaptive, and they can lend well to rare diseases, but we need to be mindful of challenges. In pediatrics, very, very few pediatric RCTs use adaptive methodology, but you can see that being applied for transfusions, antibiotics, ECPR temperature, and for neuroprotective bundles on ECMO in the future. We know that pragmatic trials are probably the future. We've seen that in the UK Pediatric Critical Care Study Group, but research prioritization is important. And finally, the important questions that we need to answer remain in ECPR, in bleeding and thrombosis, in our artificial and intelligence, and using patient records for clinical diagnosis. And with this, I'd like to say that international collaboration and networks are important, research think tank, a momentum to leverage national and international funding, and finally, children are important and research is crucial, and collaboration, high volume experience in research, and together we can do it. Thank you.
Aparna, thank you very much. We do questions at the end, as we said. And our last speaker now is Roberto Lorusso, full professor of cardiac surgery from Maastricht University in the Netherlands. He's also responsible for research within ELSO and is the current honorary secretary of EuroELSO. Roberto, welcome. You are going to talk to us about unmet needs in research in ECMO. Thank you very much.
Thank you very much. Thank you, Thomas, and thank you for all the chairmen. Well, it was quite a difficult task. I will not address the ECPR or pediatric because it was already spoken before. This is my disclosure. So I just would like to start. I mean, Alain already alluded to that and explained very clearly, but I just want to say that we are also experiencing quite difficult times for research, particularly in clinical research, in particular in some settings like cardiogenic shock, as you can see. So what should we be? I don't really know, but I think we have to certainly react and look at what are the weaknesses of what we are doing or what we are not doing or what we don't know. I just want to mention, and Alain was really doing a very careful and meticulous job, but I just want to say that if you look at some of these features, like cardiac arrest rate, the pure neurological outcome, I've never seen almost 25% of patients in cardiogenic shock having a pure neurologic outcome, at least in my practice. This 12.5% in ECLS in the control group, conservative, standard treatment, well, then almost 26% of MCS in the control. So was it ECMO versus MCS or ECMO versus medical therapy? I didn't understand. Less than 6% of the unloading. And finally, I think also the type of patient, I think the ECLS group was certainly much, worse in terms of cardiac status. But we have other studies, like the Euroshock, very, very limited study. But if you look carefully at the outcomes, look at the curves here and there, I'm not really sure, although it's not significant. Again, very small amount of patient, very, very, I would say complicated, analysis and data interpretation. I'm not sure this is really a nice provision, nice contribution to research. Indeed, you can see some of the editorials came out addressing the critical issues of some studies. This is one of those, looking and saying, well, okay, but the outcome, can you really do what you presented? I mean, you have to really include some other outcomes, some other endpoints, which were not included in the studies. Sorry for that. So, but just to say that the registries are really important, and in the future, the data platform or other analysis. But also the eligibility. So are these studies really addressing the real world? This is a little bit different because you can see that at the end, the real world, again, in the clinical studies is not absolutely witnessed. And I think this is something that we have really to think carefully. So are our study going to really represent the everyday, the daily and routine work and patients? I'm not sure. And again, you have some data you have to take and draw some conclusion. It's very difficult. And I believe that the majority of people are, at the end, they read the conclusions, and I think, as always, we say the evil is in the details. And we know instead that sometimes something happens, and this is the positive danger shock. And I think this is, I mean, thanks God, something that is finally providing some good results. But I don't want to say good results are the positive ones and bad results are the negative. I mean, the issue is this study was much, much better performed, for instance, than the ECLS shock trial. So is this the issue? Well, we have to really, it's an unmet certainly need, and we have to understand more. Prone positioning, we know that was really something important in COVID. We know that recently the Alain group showed this study. I think we should do something more in the future because this is an important part also of the daily RDS patient management. And so we should know if really we have to skip this treatment, the management. So I think we need a little bit more investigation in this aspect as shown by the results. So I think really we need to do a little bit more in this setting. What about anticoagulation? I could say anticoagulation and thrombosis or thrombotic events. I think this is really something I believe we didn't study that carefully in the past. And I think that, you know, what kind of anticoagulant, what kind of, you know, a measurement, I think still we are very far away. And I believe that we are something like that. So going on within the fog and without really knowing very much. And I believe that we really need to have better strategies, either for treatment, either for monitoring, either for control, either for, you know, even managing the complications. And I think this is certainly an unmet need in the ECMO world. What about prognostication? Because, and the device selection application, this is another big word. And I think it's very, very difficult. Because what is prognostication after all? And I think I always tell my collaborators, well, if you do not believe on what you are doing, you should just go out and not be with us. Because, you know, skepticism and hope are really, you know, such a delicate balance. So you can believe in what you're doing, or you can say, well, this is really waste of time, energies and resources. I think we have to really do that better. So we have to focus, we have to be motivated and really believe in what we are doing. I don't think this is really done today. And of course, all the scores, you know, that we are going, or we generated, or we are going to generate, we have to understand that this could be very critical because you can use all these scores in the patient selection, patient management. So we really have to be more careful, and I think to put a lot of resources in that because we really need to have better predictors and also reliable. And also the type of device, I think that we have to be also careful on that. Sometimes we say, okay, this device doesn't work on that. Well, was this device really the best one for that patient? I think just to mention this study, they compared, you see, Impella CP versus VA ECMO. I mean, how can you do that? I mean, it's like comparing a bike with a Ferrari. So, but they look at that and they say, well, we have to be careful. Of course you have to be careful because you cannot sometimes even compare a device which is absolutely less powerful with maybe also different complications. And I think that I want to show you also this because it's important to look at a combination of devices. Yesterday I discussed about Impella, but you can see along the time that the adjunct of a second device is going to be the case more and more, and in the future will be. So this is something that we have to study better. It's again an unmet, they say, unrecognized or little studied issue. So we need to understand what is the best combination of tools. And you can see now we know ECMO, Impella, intraortic balloon pump. how is it going, what is the interaction, I think this is really something we should address and study much, much better. And you can see, because when also are we going to apply these combination devices immediately, later? I think this is very important. In the future will be, and we know we have some studies ongoing, like unload ECMO, remap CAP study. So I think this is just to say that it will be a more and more important aspect of our activity regarding mechanical circulatory support. And you can see here, just comparing Impella versus CP versus 5.0, of course, you have different results because they are different machines with different power. So I think we have really to be careful, not trying to compare apple with oranges. I mean, we have to do that much better studies in the future, and looking also at the device selection, device application, the interaction. This is going to be really more important. Was mentioned by Lakshmi before. This is also, we know in our daily life, artificial intelligence is coming. It's not only coming, it's jumping. It's just jumping on us. And in this setting, in our setting, it's going to be even more important. This is a very nice paper just recently published with some nice results. And really, I would say that we should thank this group for this contribution, because it's just a clue of which are the potentials of using artificial intelligence and machine learning in the mechanical circulatory support. This could be a precious help towards the patient selection, the device selection, device application, as I mentioned before. But this is one of my, I would say, mission, because again, I believe, as I said yesterday and the day before, if we will be able in the future to reduce markedly and dramatically the complication rate, or even being able to avoid the complication in mechanical circulatory support, there will be no issue. Patient in cardiogenic shock, patient in cardiac arrest, patient in severe RDS, the only solution will be mechanical support or artificial or with machines. And I think we know still we are not doing a great job in some respects. We have really tremendous, dramatical and fatal complications. We have to really be able to understand more to prevent or reduce and handle that better. Sorry, I'm a cardiac surgeon. I know that amongst the worst results we have in ECMO is post-cardiotomy, unfortunately. And we studied that thanks to the registry, more than 7,000 patients. And you can see at the end, no whatsoever improvement in the last decades about the in-hospital survival, which is really, really disappointing. I think we really need to, this is a tremendous unmet need. We kept on doing without looking at the results, without thinking ourselves, are we doing the right thing? So I think there is an issue because these patients are really complicated. These have a lot of comorbidities, a lot of bad and, let's say, negative predictors, factors which can really impact negatively the outcome of using mechanical circulatory support. So we have to put additional efforts to understand how we can handle better this patient, timely, and so forth. So I think this is going to be very important. ECMO management. We have been really doing a lot to handle this patient better, and I think one of the aspects is awake patient. And I think this is going to be more and more the practice in the future, but still, we do not know exactly when to do it, if we have to do it in all patients, and the strategies and the management doing that, either in adults, but particularly in children. We have a group of people who are looking at that, and I'm really, really proud of these fellows and collaborators, because I think there is a lot to do, not only in adults, but particularly in children. As you can see here, we have maybe innovative versus conventional approach, but I think this is still an unmet need, and I think in the future will be a very important part of our research. And to finalize, I think this is something that I would say it's very neglected. We think always that if the patient is discharged, leaves the hospital, the work is done. That's done. Well, it's not so simple. We know more and more, particularly in children. And I think that we have to be more careful how the patients are doing after the discharge. And we know that we have to understand better if the quality of life is still acceptable after such a very complicated and perilous journey, as it was said before. So ECPR, cardiac arrest, RDS, and we knew that actually we have been exposed to that in COVID period. Are these patients doing fine at mid or long term? We need to address, we need to really do better research, better follow-up to understand that. And we know that sometimes the results can be surprisingly good or surprisingly bad. So I would like to finish to say, as I said yesterday, we have to be aware that if we conduct bad research, well, this will kill more patients than the underlying critical illness. This is really something that we have to be responsible with. And particularly, I think the complications of our daily activity are also impacting our patient outcome. So these two things, research better performed and also MCS or ECMO better managed, I think will be our future and upcoming tasks and challenges for sure. And just to show you, as Thomas mentioned, that now also decided to invest a lot in research, and I have really the privilege to chair the research committee. And I think we are now planning a lot of studies, really looking at all these unmet needs that I mentioned before. So in conclusion, I think that, of course, we have some issues like prognostication, AI and machine learning. Post-cardiotomy, we really need to understand more and doing better. Early and long-term outcome, awake patient, anticoagulation, but particularly reduction of complication has been an unmet need so far. We need to do much better. And overall, I think better quality and more clinical studies are our really challenge, our mission, and our really target for the future. And I thank you for your attention.
Thank you so much, Roberto, for that talk. I will invite now Jan and Aparna to join Roberto on the podium for us to have discussion and the roundtable. In the meantime, I would like to ask you guys in the room for questions. Do you have some specific questions about the methodology, the design, the outcomes which have been discussed in these talks? Please, if you have a question, go to, there's 2 microphones here in the room. No questions, so I may ask the first one. There is a question. Great.
Hi, Valerie Sands from Cincinnati. Great talks. I just had a question. We had I think around breakfast this morning, a symposium about, a little bit about AI and big data. Are any of you in your institutions using that as kind of a quality or performance improvement research, your real-time data capture of your program performance?
Absolutely. We are now busy with some big studies with using AI and machine learning. Just to make an example, we are almost finalized, thanks to the EuroELSO registry, study about post-cardiotomy with almost 13,000 patients. And then we need to validate. So our now really, how to say, dedication is towards creating substrates of, with the also Joe Tonna, the chairman of the EuroELSO registry, we are planning to do more and more this kind of investigation using AI and then machine learning, and then using external registries like STS or other studies to validate and trying to find more, conclusive data. But I think the future is there. The issue in ECMO is sometimes it's difficult to find numerous, the patient cohort. But I think with all this registry going on, maybe we will have more opportunities. Definitely, the road is there, and we will have more and more information about that.
I'll just briefly comment. In our institution, we're just implementing new PDMS for patient monitoring, which is a little short way, hopefully, to go. But the aim of the OSIRIS open data platform is exactly what you were asking: to gather big data and to have we have an ambition to have a tool or API or whatever translating environment to collect the data from different PDMS systems and then look at those data, how they can be helpful for prediction or intervention assessment, and of course running some AI protocols.
I just want to say, I think AI definitely has a role, but I think it is a supplementary role. I think you need to use it in conjunction with all the information you have, and it doesn't take away the human element in trying to sort of understand and see what the trends are to make the most of it for the best outcome and use the data as efficiently as possible. Thank you.
Hi, thanks for the great talks. I'm Bridge Patel from London. Partly out some of the learnings from EuroELSO, Alain. Well, standard of care changes. So one, it's difficult to recruit patients in a timely manner. It takes 10 years. The recent Impeller study suggested that. So how in a clinical trial design will you manage standard of care? Because there's the heterogeneity of patients, but there's significant heterogeneity in management as well. So should we be protocolizing standard care arms in all our RCTs going forward? That may help the crossover as well. Just wonder what.
Yeah, those are very important questions. For sure, we need to protocolize. Otherwise, if it's do it as you do it regularly, I think there's going to be a lot of noise. And to get a signal which is bigger than the noise, you should have a very, very big signal here. So definitely, this should be protocolized. Looking at the results of the danger shock trial, there was some bizarre, weird finding about mortality in the control group, which is much higher than expected. Also difference between countries in the management, probably, because there was also major difference in the outcome of the patients. So, well, we end up with nice studies, but at the end with more questions than we had before. Not to mention the crossover rate, which is, for me, the major problem here. To get a positive trial. And I have a quick question for Jan. For your out-of-hospital cardiac arrest trial, there will be no possibility for getting ECMO in control patients.
At the end, always the treating physician is responsible for the care.
Okay.
So we are not in a prison that you would prohibit something. Definitely you would not know. We are per protocol strictly prohibiting the crossover, but at the end always, as per good clinical practice, as per all the recommendation, Helsinki Declaration, whatever, we will follow the final decision of the treating team. So that's how it is. You can only recommend. But the problem is if, and therefore we have 2-to-1 allocation, therefore we have a very strict stopping rules where to look, and actually the number of conventionally treated patients in every center, if they follow the expected number of enrolled patients before the first interim analysis is so low that we would expect that they will follow the protocol. And exactly as you are asking, and I'll tell it openly, as I said already before, our study, which actually ended up with mixed results, this is about 5 saved lives. If I didn't put those patients on ECMO and if they didn't survive, we would have a perfectly methodologically clear study with a very positive results. And I again compare this to the Enigma movie, you know, from the World War II in UK, where they have broken the code of Nazis of the communication, but they couldn't disclose, because for saving next action, they would save a couple, but they would lose thousands. So for saving thousands, you have to lose a couple to prove the benefit. And that's the problem. So following protocol, following the randomization to avoid crossover means that you simply have to let some people die, but they're actually dying just in your head, in your mind. That's your alibi to do something that is not proven. And if you don't do that the correct way, you will never prove the benefit of the intervention. And when it's not never proven, you will lose the chance to save hundreds of thousands of next patients. So this is always the decision of the team. And it's also the reason why we couldn't took on board a lot of large performing centers, because they were not able and they were not willing to follow the protocol. And they said it openly, we consider it a state of the art, we're going to do it anyway. That's how it is.
I would like to underline something, in my point of view, that we should really admit, all of us. Once you finalize and publish a study, you should be fair and correct enough to say, well, we didn't perform very well. Myself, part of the inception, we did a lot of mistakes. And I think that some of these mistakes led to the negative results. But we need to admit that. Otherwise, we keep on doing bad jobs, as I said. And I told Thiele, you cannot now go on and saying ECMO doesn't work, because you did a bad study. We did a bad study. Are we really able and ready to make this, statement? I don't know, and I think we should learn from our mistakes. Instead, we are publishing because it's in the New England, okay, fantastic. No, we publish because we did a big effort, we arrived with some, but then we should make a debriefing and say, okay, now what? I think that when I was trying to convince my colleague to go to the cath lab with an ECPR patient for the ECPR, and everybody was against me, I think now, maybe some people are thinking that cath lab is better than emergency department, maybe. But just let's discuss. And this is the same thing for the cardiogenic shock, for ECPR, for RDS. So we started the study 10 years before, and 10 years after, maybe we have different opinion, a different perspective. But we should be ready to sit down around the table and admit our mistakes and do better studies for the future. I don't see that very much every day.
Thank you for the session. Ali Al-Hazmi, I'm from Saudi Arabia. I'm the National ECMO Leader for Ministry of Health. I understand the improvement to find some results, since we are in this dilemma where the studies are not showing what we see at the bedside. A question, in addition to improving the methodology and the inclusion criteria and the evolution pathway, do you see that intention to treat as the analysis way is the best way to address and to show the results? So probably that's where we also need to put some light. Thank you.
No.
You hit the knob. Of course, there's a problem, but that can be avoided by, avoiding crossover, and that's how the studies are still being done. And it's kind of a state of the art in the methodology of studies. We have here experts on other types of studies, different types of methodologies, Bayesian one, the adaptive trials. At the end, a robust methodology following the protocol may end up in a well-performed study with which will prove your hypothesis. That's how it is. But also from the crossovers, this is important information from the crossover, how actually those patients where you cannot stand with the protocol, how was the end? So this is also, and even more and more studies which did have a crossover now, as you can see, they publish their per protocol analysis as treated analysis, and more journalists are accepting them because they feel the importance of those informations which are sometimes hidden in the intention to treat approach.
So probably protocol, as per protocol analysis, is it reasonable? Because in the end, 50% from this arm and 30%, that's practically 70% of your population are getting the therapy. So probably it's an area to discuss. So I want to hear your concept about it.
The issue, think about the crossover. Think how this can happen so differently from center to center or in the same center, the kind of physician deciding to make. The decision there is so variable. And I think crossover should really be considered a failure treatment. So maybe secondary endpoint, okay, failure treatment. And then is another part of the study, but should not, intention to treat. I discussed endless times with the statistician. They try to defend that, but in my point of view, this is really the major issue of clinical trials.
I agree with you. Thank you.
Antonio?
I like to bring up the problem of equipoise because I suspect, I believe, that most of our studies are not conducted with equipoise. I don't know how to solve this problem because to do a study on ECMO, you need an expert team. The expert team normally believes in what he's doing. And if you are a believer, you cannot be equipoised. And that is so much so when you have a lot of crossover, because if you do crossovers in your study, it's because you are a believer. So I don't know how to solve this, because the randomized clinical trial, in theory, should be led with equipoise, that you really are just as innocent with and look at what's going on. But with this kind of study, it's very difficult. Perhaps this is partially corrected by a Bayesian approach. I don't know. I expect these ethics people, ethicists and statisticians to solve this problem, because they set the rules for the randomized clinical trials, but in our situation, it's very difficult to follow.
Antonio, if I may tell you one thing, look at the Inception trial. Median duration of ICU stay, 1 day. Well, and when I tried to make an interim analysis with all the other members of the steering committee, they said, well, in the Netherlands, a lot of times the family members ask to stop the treatment, but 1 day. So I think the equipoise that you are alluding to is not only the believers or non-believers, but also social and religious aspects which can really impact a study outcome and results, because again, medium duration, okay, ECPR, but 1 day is really little.
A little bit in that line, you're assuming the role of a simple clinician, which I am. I'm always worried if somebody starts a randomized control trial in this critical population, because I'm afraid the result will be not in my line, and it may even change practice of therapy. It may change guidelines. So in the end, I think an RCT, maybe exaggerated, may kill people. Like after ECLS shock, my colleague said to me, well, if I have somebody in cardiogenic shock now with acute myocardial infarction, I need not bring you anymore, because it doesn't help anyway. So would it not be time that we communicate a little bit to the medical society that RCTs in this critical population do help but are not as reliable as RCTs with a medication? What do you think?
There's more aspects. I think the problem of non-possible blinding of our interventions is the major one. So if you cannot blind the intervention, you cannot actually assess properly. But there's been first at least 2 trials, as you know. Box trial was perfectly methodologically provided with blinding of the intervention. The Orbita 2 trial on PCI was also blinded, both for the patient and for the treating team. And you know, Thomas, problem is, you said, if it doesn't go into your line, because you're somehow, you know, in your tunnel vision as a clinician, as we all are, and then you have your own ways how to do things, but seeing your VA ECMO patient with brain bleeding, you probably reconsider whether, if this patient wouldn't have an ECMO, probably will have a brain bleeding or other complications. So I think this is not as easy question. It's not as easy that we are killing, you know, clinical practice by providing RCTs. We desperately need the evidence for what we are doing because we are facing consequences of the interventions we do. We do those interventions because we just think it should help, because physiologically it works, but there have been many physiological hypotheses that are obvious but never worked actually in clinical medicine, and that's important, and even led to the harm to the patients. And I have shown at least 2 examples, like anti-arrhythmics in MI killed more Americans than Vietnam War and things like that.
Okay, it's time to wrap up on this session. It was a great pleasure for us to be here to moderate this session. Also a great pleasure to have these very nice speakers and the very nice discussion about the very complicated issue is the design of those trials. And I'm sure in the coming years we will still discuss the result of upcoming trials, and the debate will be ongoing for years, maybe decades, how to best treat these patients. Artificial intelligence may help. I'm not sure it's really intelligence. It's artificial for sure, but it may help also to design better trials. So thank you so much for being here. And we have now 2 lunch symposia in which you might have also good data and information. Thank you so much for coming. Bye.